Hello, everyone, and welcome to this month's Simon Says Expert Series. I am Dr. Nephew, and I am an assistant professor of medicine in the Division of Gastroenterology and Hepatology. I'm the Associate Vice Chair for Health Equity for the Department of Medicine and a member of the IU Comprehensive Simon Cancer Center. I'm a physician scientist and a liver doctor who is very passionate about health equity. I study barriers and access to liver cancer care, focusing on the social and structural determinants of health. Now that's enough about me. I'm very thrilled to introduce our speaker today, who is Dr. Francesca Duncan. Dr. Duncan is an assistant professor of clinical medicine in the Division of Pulmonary and Critical Care Medicine at IU School of Medicine. She is an emerging lung cancer disparities researcher at the IU Simon Cancer Center. Her work includes the exciting new field known as socio-epigenomics, which has emerged as an integrated field focused on the identification of socio-environmental factors and their influence on human biology through epigenomic modifications and how that contributes to health disparities in lung cancer. She is also involved in lung cancer at the lung cancer screening program at Eskenazi Health. And so I'm really thrilled to help moderate and hear her talk today on health disparities across the continuum.
Well, thank you so much, Dr. Nephew, for that introduction. Thank you so much for the invitation as well, IU Simon Says, for being able to speak with you all here today. And I'm delighted that each of you all have joined today to hear this talk. And I am aware that the individuals that are going to be participating in this talk are from various backgrounds, maybe physicians, nurses, scientists, researchers, and just everyday people that want to learn a little bit more about health disparities in lung cancer. And so I hope that today, each of you will learn something from the talk today. Remember that we have received questions, so there'll be some questions that we can discuss at the end. And if you have some questions, feel free to utilize the chat, and I'll be happy to answer those at the end of the talk. So I'd like to start by saying that I have no financial disclosures, and some of the research that I'll be talking about here is funded by these three sources that I have. So let's start by talking a little bit background information about lung cancer. So lung cancer is estimated that 236,000 people in the US would be diagnosed with lung cancer last year. And lung cancer is the leading cause of cancer mortality worldwide, estimated to cause 1.6 million deaths a year, with a 5-year survival rate of 19%. And this is an average of those individuals that are diagnosed with early and advanced stage disease. And Indiana has an age-adjusted lung cancer incidence rate of 70.2 per 100,000, significantly higher than the national average, here highlighted in the green, of 58 per 100,000. And so this is definitely a report card that the state of Indiana does not want to be a part of. But I want to pause here by saying that when I'm speaking about incidence rate, I'm talking about the number of new lung cancer cases per year, which means that you can see that lung cancer is a huge problem, specifically for the nation, but also for our communities and the state of Indiana. So when it comes to common symptoms of lung cancer, these include persistent cough, shortness of breath, repeated respiratory infections, sometimes coughing up blood or hemoptysis, shoulder, arm, chest, and back pain, and even unexplained weight loss. And so I pause here to show that these symptoms are not necessarily specific to lung cancer. And so these can mimic other things such as pneumonia, maybe even cardiac and even GI issues. So it's important that we are all astute to these symptoms. So there are two main types of lung cancer, and that includes small cell and non-small cell. And non-small cell makes up the largest proportion of lung cancer types, with 4 types here being adenocarcinoma, squamous cell carcinoma, large cell, and other types including carcinoid. And you can see here that adenocarcinoma makes up the largest proportion of non-small cell types, and 15% of cancer types include small cell. So I put this picture here because we know and we're aware that cigarette smoke is linked to the development of some types of lung cancer. And there are other individuals with no direct history of smoking that also develop lung cancer. But these are the lung cancer types that are typically associated with smoking. So specifically, small cell carcinoma and squamous cell carcinoma are typically diagnosed in individuals that have an increased pachyeral smoking history, where adenocarcinoma typically is diagnosed with people who may have no smoking history, may even have some secondhand exposure, or maybe those individuals that, report smoking 10 cigarettes a day, or these kind of intermittent smoking habits where they're smoking more heavily for a couple of months, then abstain from cigarette smoking before picking it back up. So let's go right ahead and kind of talk about disparities across the lung cancer continuum. And so I think it's important for us to know that with the COVID-19 pandemic, I think there was an increase in talking about health disparities, but lung cancer disparities and disparities in general have been going on for decades. And the term health disparities was coined actually in 1990. And let's think about what are some other things that were kind of going on around that time in the 1990s. So this is the Hubble telescope was launched into outer space. During that time, Nelson Mandela was released from prison after serving 27 and a half years in a South African prison. The classic movie here, Home Alone, starring Macaulay Culkin, first aired. And for my sports fans, the San Francisco 49ers won 2 back-to-back Super Bowl titles. And so the term health disparities is one that came about in 1990. Now, this term is not meant to describe disparities in terms of specific groups. So let me clarify what I mean there. We know that there are certain diseases that affect different age groups. So we know that there are certain diseases that affect newborns, adolescents. And for example, those individuals that are older, we know that they're more likely to have cardiovascular disease and things of that nature. So we're not talking about those types of health disparities, but rather disparities that disproportionately affect people from socio and economic deprivation. So the Healthy People 2020 definition of a health disparity is a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. And it adversely affects groups of people who have systematically experienced greater social or economic obstacles to health based on belonging to these various groups. So now let's kind of define health disparities. And I think it's important to note that disparities are preventable, which means that there are things that you and I can do to help prevent disparities. And so these are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. There's also an increased presence and severity of certain diseases, poorer health outcomes, and greater difficulty in obtaining quality healthcare services for these specific groups. And lastly, they are related to inequities in education, poverty, access to care, geography. We know that there are studies that have shown based on simply where you live, you are at an increased risk for having certain types of medical conditions, and even environmental exposures. So those of us who do work in the health disparities space, we are very familiar with imagery such as this one. But I want to first start by describing what we see here on the left. So equality means giving each individual or a group of people the same resources or opportunities. So you can see here, the 3 gentlemen here are provided the same resources, but despite that, they still don't have the ability to receive access or to actually see into this particular game. Where equity is a little bit different. So this describes that everyone comes with their different circumstances. And therefore, the issue with equity here is that we try to allocate resources and opportunities needed to reach an equal outcome based on people's specific needs. And I would argue that equity is the goal in terms of healthcare. So why do these disparities exist? Well, they're driven by social and economic inequities that are rooted in systemic racism. And health disparities are extremely costly. I mean, it's estimated that $93 billion in excess medical costs can be attributed to health disparities. And people of color are those that are disproportionately affected by health disparities. And this particular group is expected to account for 52% of our population by 2050. So addressing disparities is becoming increasingly more important. So let's dive in and talk about lung cancer disparities and incidence and mortality rates. And so when it comes to incidence, which remember I said those are new cases of lung cancer per year, African American or Black men have a higher both incidence and mortality rate compared to white men. And the same is true for African American or Black women having a higher incidence and mortality rate when it comes to lung cancer. And we know that stage at the time of diagnoses is the most important predictor for survival. So individuals diagnosed with earlier stage disease have an increased survival rate just by the mere fact that there are more options of potential cure when being diagnosed at an earlier stage. We also know that Blacks are more likely to be diagnosed with more advanced stage compared to white individuals. And that there needs to be an emphasis on identifying risk factors, maybe even other than cigarette smoke, in order to reduce lung cancer risk and equitable early detection strategies. So let's take this journey with me. And so we're going to start by kind of talking about disparities at each point along the lung cancer continuum, starting with screening. So those of us who do work in the lung cancer space are very familiar with the National Lung Cancer Screening Trial that took place in 2011. And this was a randomized clinical trial funded by the National Cancer Institute, where essentially what they looked at were differences in screening modality comparing the CT scan here at the top left, or excuse me, top right, and the X-ray at the bottom right. And they were looking to see if there were differences or if there was a reduction in lung cancer specific mortality in participants who are deemed high risk for the development of lung cancer. And the results of this study, in fact, show that there was a 20% relative reduction in mortality from lung cancer with low-dose CT scans compared to the X-ray. And mortality of any cause was also reduced in the low-dose CT group. So there were some problems with this study, and I think, as I've mentioned here before, that Black individuals are disproportionately affected by lung cancer. And some of the problems with the study was the sample that was included in the study. So you can see there were about 53,000 individuals in the study, 2.1% Asian, less than 2% Hispanic, 0.3% American Indian or Alaska Native, and Black individuals only accounted for about 4.5% of the participants. And these are some of the qualities or characteristics of those Black individuals in the study. So based on this particular study, it was determined that the guidelines for screening at that time were ages 55 to 80, and those individuals that had a 30-pack year smoking history, those were current smokers or who had quit smoking within the past 15 years. And so this was exciting news for us. But there was a study that came out in 2019 that really dived in on the fact that that initial study really didn't have a significant number of Black individuals in that study. So many argue that was it fair to say that maybe the same screening guidelines would be applicable to Black individuals. And they also didn't really consider the important racial differences in smoking patterns between racial groups. So for example, there's a larger percentage of adult racial minority populations that are considered light smokers. And these are smokers that smoke less than 10 cigarettes a day compared to white adults. And Black smokers have a higher risk of lung cancer compared with white smokers, despite smoking fewer cigarettes per day and having lower cumulative pack years. And for the same quantity of cigarette smoke per day, Black smokers remain at higher risk for the development of lung cancer compared with white smokers, even after accounting for individual and socioeconomic status, including other risk factors. And so these differences in smoking patterns between Black and white individuals led researchers to really wonder whether or not the prior guidelines would be applicable to African American or Black individuals. And that led to this particular study in which this time, you can see here the population include about 32,000 Black individuals, about 16,000 white individuals, and you can see various differences between these two groups, with the median age at lung cancer diagnosis for Black individuals about 59, whereas for white individuals was 64. In terms of PAC years, the median PAC years was 17.5 for Black or African Americans and 32 PAC years for white individuals. So you see various difference there. And even when it came to cigarette smoke per day, Black individuals smoked 10 cigarettes or about half a pack compared to white individuals who smoked 20 cigarettes a day. So they really looked at these differences and determined that solely by decreasing the PAC years from 30 to 20, and by reducing the initial years for screening from 55 to 50, that they would be able to, in fact, increase the sensitivity of screening for Black individuals. And now more Black individuals would be eligible for screening in hopes of identifying lung cancer at its earliest stage. So these are the new recommendations now: ages 50 to 80, a 20 PAC year history, and those individuals that are current or smokers or who have quit smoking within the past 15 years. And it's important to note that under the Affordable Care Act, all insurers were required to cover lung cancer screening with no cost sharing. And Medicare and Medicaid follow the same age and PAC year history, but the recommendation in terms of the oldest age for Medicare and Medicaid patients for screening is 77. So we're excited. Lung cancer screening via low-dose CT scan can reduce mortality by 20%, but still, 12 years after this seminal study, only 4 to 6% of people that are actually eligible for screening are actually being screened. And so I think for that reason, I think we deserve an F, a grade of F when it comes to screening. But I'm going to talk about ways that we can improve upon that. I think it's very important to pay attention that while efforts to promote lung cancer screening are taking place, this can widen the health disparities gap because those individuals that are disproportionately unprivileged in terms of not having insurance, maybe not having transportation to be able to actually go to these lung cancer screening programs and actually be able to afford lung cancer screening, those populations are still going to continue to be disadvantaged if we don't do things to ensure equitable lung cancer screening uptake. These racial differences at stage of diagnoses are going to be exacerbated by screening. So some contributors to disparities in screening include race and ethnicity, which is sometimes synonymous with socioeconomic status, racism and mistrust by patients, rurality or proximity to an accredited lung cancer screening program and access to low-dose CT scans, environmental and occupational exposure. So we know that secondhand smoke can lead to lung cancer, radon, silica, and asbestos exposure. And when we think about this, which groups are more often likely to have these types of jobs? And so the fact of knowing this, occupation in itself can lead to disparities in lung cancer. So let's move on from screening to diagnoses. And so this is some of the work that our group has done here at IU Simon Cancer Center, where we looked at the effect of socioeconomic factors on stage at diagnoses and trying to see if there are any factors that may differ comparing Black and white individuals. And what we found here is that factors associated with advanced stage included being a male. So again, males were 1.5 times as likely to be diagnosed with advanced disease, being uninsured, and then Black individuals were 2.3 times as likely to be diagnosed with advanced stage disease. And so when it comes to cigarette smoking, we know that it is linked to smoking. And while our results show that there was an association, it was not statistically significant, which may argue that these are some of the risk factors that we should start thinking about when we're trying to determine those factors that should go in determining screening eligibility. So here's another paper that was published in Chest in November of 2022, looking at racial disparities in lung cancer stage. And so this is another group that, similar to the work that we've done here, showed that Blacks were more likely to be diagnosed at advanced stage compared to white individuals, and specifically participants living in neighborhoods with greater deprivation, so worse education, less access to care, lower income, worse poverty. These were individuals were 58% more likely to be diagnosed with distant or advanced stage lung cancer. And patients with health insurance, history of COPD, or received colonoscopies were less likely to be diagnosed with distant stage disease. And you may ask, well, why is that? Well, these individuals with health insurance, they likely have access to care. They may even have PCPs. Individuals with a history of COPD are more likely to utilize the healthcare system. So these are people that are presenting to our emergency departments with symptoms of shortness of breath, likely getting a chest CT, and maybe even finding cancer in those early stages, which is why some may argue that having COPD should be considered as one of the eligibility criteria for lung cancer screening. And even receiving a colonoscopy, because these are individuals that probably have a PCP that's probably talking with them about preventative care services. And so these individuals are more likely to be diagnosed, less likely to be diagnosed with distant or advanced disease. So when we kind of think about this puzzle here about why are we having these advancements in screening, advancements in lung cancer care, and still, despite those advancements, we're still seeing these social inequities that may persist. And this describes this fundamental cause theory in which social inequity in access, flexible social resources, for example, wealth, income, education, and racial privilege are those things that are actually driving our population health inequity. And individuals with high socioeconomic status can use their resources to avoid disease, seek treatment, and adopt healthy behaviors that improve their overall health. And last, there have been studies that have shown that racism causes racial differences in health outcomes and mortality independent of socioeconomic status. All right, so let's move on to disparities in treatment. And so again, some of the questions that we were asking here were, are there disparities in stage appropriate treatment? So there are evidence-based guidelines in terms of, depending on the stage that you're diagnosed, specifically for non-small cell lung cancer, there are guidelines to say what type of treatment should be recommended to our patients. And we were interested in seeing if there were any differences when it comes to treatment. So what we found here, very similar to what's been seen in other studies, is that Black individuals, seen here by the black line, had worse mortality compared to white individuals here in the blue line. And you can imagine here along the x-axis, this is time from diagnosis to death. And you can imagine those individuals diagnosed here at the top left are those individuals probably diagnosed with advanced disease that unfortunately died very quickly within the first 2 years. But as time increased, you see this widening or increased gap in terms of survival rates between Black and white individuals. And we were interested in what are the reasons for these racial survival differences, because these are individuals that probably were diagnosed with early stage disease. And in doing so, we found that individuals that were uninsured were 80% less likely to receive potentially curative surgery for early stage disease. And Black individuals were about 50% less likely to receive potentially curative surgery for early stage disease, regardless of insurance status. And this is a review article that also looked at disparities in surgical management of early stage non-small cell lung cancer. And there are several papers that they looked at that again show that Black individuals and Hispanic individuals were less likely to receive potentially curative resection for early stage disease, which is the gold standard when it comes to the management of early stage non-small cell lung cancer. So disparities in the treatment of advanced stage disease. And so what we looked at were, are there racial differences in the receipt of appropriate treatment for advanced stage disease? And we actually found that there were no racial differences in terms of that were statistically significant in terms of receiving stage appropriate treatment for advanced disease based on race. But there were other studies such as this one that actually found some differences. And what they were able to find is that Blacks with advanced lung cancer were less likely to receive guideline concordant treatment than white patients. And there's also this conflicting data as to whether Black individuals have inferior treatment responses or even more severe toxicity with some of our chemotherapy agents, which may impact survival. And the reason for this conflicting data is that Black participants only comprise about 5% of cancer clinical trial enrollment nationally. So it's really hard to say whether or not these differences can be explained by the actual inferior treatment response or the fact that we just don't have enough Black individuals enrolled in these clinical trials. And so lastly, moving on to disparities in end-of-life lung cancer care. And so as I mentioned, disparities exist at all points along the lung cancer continuum. But this is the point in which I think we must slow down, because I think we should start thinking about the fact that an end-of-life care is when our patients deserve our most compassionate care. And racial bias and inequities can greatly impact the quality of life of our patients and their families. And sometimes not offering aggressive treatment and instead saying yes to supporting our patients and their families is the treatment our patients need the most. And a reminder that end-of-life care is lung cancer care. And this includes providing care to those individuals who are nearing the end of their life and who have stopped treatment to cure or control their disease. And this may include physical, emotional, social, and spiritual support for patients and their families. And the goal here is to control pain and other symptoms and make our patients as comfortable as possible. And so there are also disparities, racial and ethnic disparities when it comes to end-of-life quality care. And so again, Black patients with lung cancer are more likely to receive aggressive and non-beneficial medical care at the end of life. They are more likely to have a greater odds of seeing ICU physicians like myself, or even having these emergency department admissions. And some would argue that maybe it's because they're not being explained in terms of what type of symptoms their loved ones are going to be having toward the end of their life. And Black patients with lung cancer are more likely to undergo intubation and mechanical ventilation when these are and dying on the ventilator, and robbing our patients from the opportunity to be able to talk and communicate and be conscious with their family members as they're transitioning. And Black patients with lung cancer are more likely to be provided less information from providers about diagnoses, prognosis, treatments, and end-of-life care. And also, Black individuals have lower utilization rates of hospice, and even when enrolled in hospice, Blacks are more likely to have difficulty accessing medications in terms of pain medications, and caregivers are less likely to receive home visits from providers. So what can we do to reduce these disparities at each level? Well, I think that's what comes about when some of us as researchers are really focusing on what can we do to reduce these disparities. And so my colleague, Dr. Edwin Jackson, and I recently have received this PRIME grant here at IU, where what we are trying to do is improve the rates of equitable lung cancer screening by working with our primary care providers, residents, and other trainees in ensuring that we're talking about lung cancer screening at every visit, and also utilizing the care of our nurse managers to act as nurse navigators to call and talk with patients about lung cancer screening. And I also have given a talk to our medical students when kind of preparing them for entering clerkships. And I came up with this mnemonic that I think applies to just the key to screening and also eliminating disparities, all about communication with our patients. So I think we must acknowledge the mistreatment and medical exploitation of certain racial groups in this country and certain ethnic groups in this country. And we must listen to understand different patient perspectives and the barriers and fears that impact the utilization of the healthcare system. We must resist the urge to judge patients based on our own implicit bias and assumptions. And we must build deeper connections with our patients by taking the time to address their concerns and conveying that building their trust is extremely important to us. And lastly, we must offer all patients guideline concordant treatment, including goals of care discussions, regardless of race and ethnicity. I like to acknowledge some of those mentors and individuals that I've worked with, including IU Simon Cancer Center for allowing me to conduct some of the research that I've been doing, the Prime grant as well. And at this point in time, I'd like to stop and end here for questions.
Thank you so much, Dr. Duncan, for that great talk and taking us through the disparities that our patients experience with cancer from screening all the way through the end of life, which I think often is not acknowledged in some of the talks that we do about cancer care. So please feel free to put your questions in the chat. I'm going to start off with some of the questions that have been sent in for Dr. Duncan. And so some of the questions that patients and listeners have are really around the incidence of lung cancer. And one question I think we hear a lot from our patients and providers is, how does the prevalence of menthol cigarette consumption, which is something that is often seen in Black communities, how does that impact lung cancer? Is there something about the type of cigarette that you smoke that might contribute to your risk?
That's a really good question. And that's something that I've actually looked into as well. So what we do know is it's not that Black individuals maybe prefer menthol cigarettes over other cigarettes, but there had been a push in terms of advertisements about these types of cigarettes, particularly in the communities of Black individuals. And so the thing about menthol cigarettes is that they contain menthol, which actually increases the addiction that individuals have to cigarettes. So the issue here becomes, well, if we are, advertising these cigarettes in the Black communities, we know that Black individuals are going to be more addicted to cigarette smoking. This is when we start seeing that Black individuals are more likely to be current smokers at the time of lung cancer diagnoses, because it's just very difficult for them to actually successfully abstain from cigarette smoking.
Okay, so there's actual addiction to the menthol itself on top of nicotine.
Yes.
So almost this compound effect. And then the targeting, advertising targeting together just creates a real space or situation where you can see this higher use in certain populations. So thank you for that insight. Another question from our listeners, which I think is also important, is this concept of kind of secondhand smoke. Certainly growing up, when I was growing up, you could smoke in restaurants, you could smoke almost anywhere, and that's changed, but some people still live in the homes with people who smoke. And so one listener wanted to know, if they had a parent at home who smoked, what are their chances of lung cancer, and should they really be screened even for lung cancer because of this exposure?
That's a really good question as well. And so the thing here, I will have to say that studies have shown that individuals that may not be smokers, but are exposed to secondhand smoke, these individuals have a 20 to 30% increased risk for the development of lung cancer. So let's think about this. If a child, per se, is living in a household where one or both parents are smoking cigarettes, and over their lifetime, that cumulative smoke behavior is definitely going to lead to an increased risk for lung cancer development for those individuals. I think that the question in terms of whether or not one should be screened is a good one. And so right now, in terms of screening, the screening guidelines in terms of what our insurance companies are going to cover are based on those qualifications that I mentioned in the talk. But there are individuals that are doing studies to kind of trying to figure out whether or not secondhand exposure and how to kind of calculate the cumulative effect of secondhand exposure in terms of should that be a risk factor that's used in the eligibility criteria.
You brought up an interesting concept of not only the cumulative burden, but when you have that exposure in your life, because, perhaps being married to someone who smokes and getting that exposure as an adult, as opposed to getting that exposure as a child, I can imagine that might have effect on your risk, as well as just how many years you've been exposed. Is there any data that you know of, and there may not be, on whether or not the risk of exposure and when that happens in your life, if that at all determines your risk for lung cancer?
Absolutely. So we know that one of the things of aging is that, all of us, our lung function kind of increases over our lifetime, and we kind of have maximum lung function around age 20. So one could argue that for individuals, for children under the age of 20 that are exposed to this cumulative smoking exposure, when their lungs are at the peak in terms of growing, that will in fact could lead to stunting their lung development. And so we know for individuals that as your age increases after the age of 20, unfortunately, our lung function continues to decline. But those individuals with increased smoke exposure and increased smoke use have a more rapid decline in lung function.
Bringing it back to disparities, then, if you think about what you've told us about the smoking in households with people of color, then you've got children of color who are being exposed. And then
Absolutely.
that creates this cycle of increased risk for lung cancer.
Absolutely.
There's certainly some other questions about screening. And you talked about this in your talk, but just to kind of really reiterate it, how often should people be screened? Are there any specific racial differences in that screening? Well, I'll start there because I think if we just answer those really clearly so people can take home that information, all providers, all patients, who should be screened and how often?
Yeah, so that's a good question. And so in terms of who should be screened, I think right now, while I think we have to kind of separate what are risk factors for the development of lung cancer and then who is eligible for screening based on the current guidelines, because those differ. So in terms of who should be screened right now and what our insurance companies are covering in terms of screening are those individuals between the age of 50 to 77 or 80, depending on what type of insurance that you have. Those individuals that are current smokers or who have quit smoking within the past 15 years. And those individuals that have a cumulative 20-pack year smoking history. So this is determining over your lifetime how many packs of cigarettes that you have smoked over that lifetime. And so those are our current screening eligible criteria in terms of screening. Now, when it comes to lung cancer screening, this is where our lung cancer screening programs are so important because the studies have shown that in order to have that 20% reduction in mortality, patients need to come back each year for screening. Mm-hmm. So it's very easy, I think, to have patients, well, if you get screening and you identify that you have lung cancer, I think that catches your attention, right? But in those individuals that you're current smokers and you get screened and that in that first screen, you don't have lung cancer, it becomes a little bit more challenging to get those patients to come back annually for those repeat low dose CT scans. And also in terms of our screening programs, that is another large part of our screening programs is tobacco cessation. And so that's another opportunity for providers annually to check in with patients and see how they're doing in terms of sustained tobacco cessation.
And so you have to be screened annually, but insurance companies are paying for this. And I think I'm just reiterating the points that Dr. Duncan is making, that even though you need to be screened annually. Now, let's say you're uninsured, you don't have private insurance, Medicaid or Medicare, but you still want to be screened in the city of Indianapolis. Are there places where you can at least get a one-time screening for free?
That's a good question. So I think that's another opportunity for another grant, I would say. But as far as I'm aware, there are no places within Indianapolis where our patients can go that are uninsured, that can go for free screening. I think the key here is that if you have insurance companies are required to cover this. But in terms of free screening, there isn't any place that you can go. I will say that for those individuals that don't have a primary care provider where they can talk with them about screening, there is on the IU Health site, there is a place where you can go and actually kind of calculate what it might cost you to receive lung cancer screening. And so you're able to put in there that you are uninsured. And then with that, you're able to kind of figure out what that screening might cost you. So it's possible that, you can pay for screening anywhere, honestly, between $50 to about $300 for individuals. You can pay for that initial CT scan, and maybe in the meantime be working on getting health insurance so that you can then, the subsequent test could be, you could qualify for that at no cost.
Yeah, there's certainly work for us to do in this space, because I think when we think about annual mammography, or even in my space, colonoscopy for colon cancer screening, there are select programs where you might be able to, it's not easy, but there are select programs where you might be able to obtain screening for free. And given the burden of smoking in Indiana, I think we certainly have to work towards some grants and funding for people who are, like you said, uninsured, but still unable to, are working towards getting their Medicaid coverage where they can go in and get screened. I think, is there any data about provider knowledge about these recommendations? Now, I was shocked to see that these recommendations have been out for 20 years. Now, I don't do primary care anymore, and maybe COVID has warped my time sense, but I was not aware that these screening recommendations have been around for 20 years and our uptake is only 3 to 4%. Is there any data, and even anecdotally, do you feel like primary care providers even realize that there should be annual screening? And if you say yes, I think they realize, what do you think about these other competing priorities? Because we're screening for everything now because our science has advanced.
Absolutely. So I think it's a combination of a few things. And so one, I can say that our primary care providers are busy. They are definitely busy with the large load of patients that they're seeing on a day-to-day basis. They're trying to talk to our patients about preventive services, from vaccines to managing all of their chronic medical conditions, to all of the other preventive care screening. And so I think one of the issues there is that they just don't feel like there's enough time to kind of talk about these screening modalities with our patients, specifically with lung cancer screening. I think there are also maybe some issues in terms of education. So as you mentioned, some providers, and I'm not solely talking about primary care providers, but some providers really aren't aware that the idea about lung cancer screening seems like something that just kind of came about. But as I mentioned, this work has been going on since 2011. So sometimes we're a little bit slow in terms of adopting these things. So I think that's one of the things that I would really like to encourage primary care providers here, that the studies have been done, they've been repeated and validated. And so lung cancer screening does save lives. And so we really should try to do that. So I think that's kind of some of the things that can kind of contribute to this.
I think there's also a lot of advocacy work in breast cancer and colon cancer that have given patients some ownership. They're so that you need to be screened for breast cancer, whether you want to get a mammogram or not.
Right.
This is something that we see. And then, of course, with even colon cancer, unfortunately, with the loss of Chadwick Boseman in the Black community, I think that put colon cancer back into the minds of Black patients, and really many patients, because he was really beloved. And so is there advocacy work? I know there must be, but how do we get lung cancer on the same map? I do liver cancer research. Nobody's ever gonna really be as excited about liver cancer because it doesn't impact as many people as lung cancer. But this is a disease that's really killing many Americans, as you showed in your opening slide. So how do we get that awareness up there like we have for some of the other top 5 cancers causing deaths in the United States?
Yeah, so I think there's a stigma also with lung cancer, right? Because there's a stigma that's associated with cigarette smoking. So there is this attitude by patients and even providers that, well, you've done something, so that's why you have cancer. And unfortunately, some of our patients even kind of feel that way. Well, I've been smoking all my life, so I'm guaranteed to have cancer. Why do I even need to go through screening? And these are great opportunities for education. I think with the breast cancer, that stigma is not there, right? It's that, unfortunately, you develop breast cancer. And so we really need to figure out ways to improve screening so that you don't develop breast cancer, that we can identify it sooner. So I think there's a stigma there. And there are lots of efforts in terms of awareness surrounding lung cancer, specifically within the IU Simon Cancer Center, also within some of our national organizations, ATS, CHEST. I'll be giving a similar talk to this at our national meeting in May. And even organizations in lung cancer now that are really kind of combining this community outreach, research, advocacy to kind of get out there and reach people where they are. I was kind of talking with some colleagues. I went to one of the Indiana Pacers games maybe about 2 months ago, and during halftime, there was a physician that actually came on the court at the game and had a message about lung cancer screening. I thought that it was brilliant. I was so excited to see that provider on the screen. So I think it's important for us to really go to where people are and talk with them about lung cancer screening.
You brought up a lot of important points around stigma. That I think that, in community advocacy and going where people are, to the Pacers games, to the fair. Finally, I'd like to ask you some questions about treatment. And so are there any kind of evidence-based recommendations about that are developing, or interventions that are developing to help patients get access to the treatment? You show very clear data about access to surgical treatments in early and late stage lung cancer. Is there anything that folks are doing to help people get the treatment they need?
That's a really good question. And I think that there are things that are coming about. I think one of those things really is ensuring that we're talking to our patients about all types of treatment. And we are not limiting those discussions to individuals based on our belief that they aren't able to pay or afford the care, or our belief that they may not want the care that we're offering. So there are studies that are looking at that are looking to see whether or not physicians' attitudes influences the care and treatment options that they offer to our patients. And I think, honestly, in order for us to really study how well our patients are doing with treatment, we really have to push getting our patients into clinical trials so that we can actually see how these medications are working for our patients. I mean, we were able to see with just adjusting the screening guidelines, we were able to improve screening for Black individuals. And so I can imagine if we're able to get more Black, Hispanic, Asian individuals in these trials, we may be seeing different patterns that may be helpful for certain groups.
Excellent. Clinical trial enrollment, and this is really making sure that we acknowledge that there could be provider bias that plays in here, and understanding how we might mitigate that. Bias can certainly be unintentional, but it can still have consequences. So I think you bring up some important points about how we improve access to treatment. Are there any final comments, wrap-up comments that you want to make, Dr. Duncan, before we part ways?
No, I mean, I really like to say thank you so much for the opportunity to be able to share with you. I hope that I've been able to shed some light on disparities and really try to hone in on that. In order to eliminate lung cancer disparities, we really have to make sure that we are providing equitable care when it comes from screening all the way to the end of life treatment plans for our patients. And talk to your providers about lung cancer screening.
Thank you so much, Dr. Duncan, for your excellent talk and this conversation. I very much enjoyed it. Thank you all for joining us today. You can learn more about next month's Simon Says and find a recording for today's session at cancer.iu.edu/Simon Says.